There are two main methods that have been used in cooling for stroke patients. One of them is systemic cooling, where essentially you cooled all of the blood in the entire body. And then there's something called selective cooling, where basically we focus on cooling the arteries that go to the brain, so the internal carotid artery and the middle cerebral artery. The main methods of selective cooling are putting a catheter in the artery, in the internal carotid artery, and then infusing cold saline, and that basically cools the blood and cools the brain as a secondary effect. And the other way is airway cooling, where essentially you're putting in extremely cold water in the airway and then cooling the internal carotid arteries and vertebral arteries, because of their proximity to the airway. Essentially, there are two main populations of ischemic stroke patients. We have our slow progressors, the patients that can be stable for hours and you can save a vast majority of the brain with successful recanalization. And then there's the fast progressors, the patients that you don't have too long to save the brain. I think that the patients that are the fast progressors, or the patients with the large core infarcts, those are the ones that are going to be able to potentially benefit from selective cooling. From the early preliminary literature on arterial catheter-based cooling, as well as cooling from the airway, there are risks associated with it, like coagulopathies. So essentially, you can have more bleeding. Your platelets don't function as well if they're extremely cold, which is a potentially worrisome thing among patients that have stroke and already dead brain. And then another potential complication is with the airway cooling, you can have aspiration, which can also, result in some significant medical problems. So there have been a number of small studies using the catheter-based cooling of the internal carotid artery, and those studies have been mainly focused on safety, not efficacy, and they've shown that it's generally pretty safe. However, there have been no large-scale clinical trials to date among patients getting mechanical thrombectomy for stroke that are treated with selective brain cooling. That's yet to come, but I'm sure it will come in the next 5 to 10 years or so. I think the key message from the presentation, number one, there's a large body of evidence that cooling has the potential to really benefit stroke patients. But number two is that there are just so many unanswered questions right now that we do need to kind of answer before we go ahead and do clinical trials, and essentially the who, what, where, when, why. Who needs to be cooled? To what degree do we need to be inducing cooling? How do we cool? What's the best method? And then when do we cool? Is it before treatment? Is it after treatment? These are the questions that we need to figure out.